right. So, hello everyone. Good morning, afternoon, evening, depending where you are. Welcome to our webinar. Remember, these webinars are joint webinars, GOHIRP and ICOHIRP. And the webinar today is called Multidisciplinary Approaches to Improve Global Health Disparities with emphasis on oral health in Puerto Rico. So we are very happy to have with us 4 academic researchers from the University of Puerto Rico with us today. Today, we will share their experiences on this very interesting topic. So just a reminder, remember we decided some time ago to have these webinars on a meeting format on Zoom, so you all could eventually turn on your microphones or cameras if you feel like it, but please try to do it at the end when will be an open discussion. So I will ask you to please keep your mics off during the presentations. And then during the presentations, during the webinar, please feel free to include your questions on the chat box. And then at the end, we will have a very interesting discussion. Okay. Also, this session is being recorded and is also live streamed on YouTube as well on the ICOHIRP YouTube channel. So welcome everyone, and I will hand over now to Professor Carmen Buxo Martinez. Carmen is a member of our executive committee at GOHIRP, very proud of that, and she is director of the Dental and Craniofacial Genomics Core and also director of the Caribbean and Dental Biorepository at the University of Puerto Rico School of Dental Medicine. So over to you, Carmen. Thank you, everyone, and enjoy the webinar.
Thank you, and hi, everyone. Welcome to the webinar, Multidisciplinary Approaches to Improve Global Health Disparities with emphasis on oral health in Puerto Rico. Our speakers today will be Professor Augusto Elias Boneta, Professor Sona Rivas Tumanyan, Professor Evangelia Moreau, all from the School of Dental Medicine, University of Puerto Rico. This webinar is sponsored by GOHIRP of the IADR, by the International Center for Oral Health Inequalities Research and Policy, the University of Puerto Rico School of Dental Medicine's Office of the Assistant Dean of Research, and the American Association for Dental, Oral, and Craniofacial Research, Puerto Rico section. Let's begin. Some reminders, please turn off your microphones, and the question session will be at the end, although you can write some questions in the chat while we're in the presentation. So first, I want to introduce our first speaker, Professor Augusto Elias Boneta. He's the Assistant Dean of Research, School of Dental Medicine, University of Puerto Rico, Medical Sciences Campus. Dr. Elias has a dental degree from the University of Puerto Rico, a Master in Science of Dentistry in Dental Materials and Preventive Dentistry from Indiana University. And he also has, honorary doctoral degree, from the University of Costa Rica. So I'll leave you now with Dr. Elias.
Thank you, Carmen, and good morning and good afternoon. I'll be sharing with you some information how the School of Dental Medicine is addressing oral health disparities in Puerto Rico through research, curricular revision, and public policy. This is a presentation is co-authored by Professor Gloria Nazario, also from the University of Puerto Rico School of Dental Medicine. A few facts about Puerto Rico relevant to the theme, so that you know where we are and what's going on here. Since 1898, we are a territory of the United States of America. We are USA citizens. Puerto Rico is located in the most eastern area of the Greater Antilles in the Caribbean. archipelago formed by the main island, that's Puerto Rico, and 143 islands, of which Culebra and Vieques are the largest and more populated. There are 7 jurisdictions in Puerto Rico. We elected our first governor in 1948. Language is Spanish, and a big portion of the population speaks English. We consider ourselves Hispano or Latino, and 98.7% of the population is Hispanic or Latino. Some demographic and socioeconomic conditions. The population of Puerto Rico is 2.7 million. It has decreased lately during the 7 to 8 years due to some economic and geographical and problems. We'll get into that. The median age is 44.5, 52% are women, and well, I already said 98.7% Latinos. If we compare some facts from Puerto Rico and the US, our per capita income is 13,000 around, and in the US 35,000. So you see a huge difference here. The poverty rate in Puerto Rico is 43%, while in the US is 10%, 10 to 13, I've seen different numbers. And our Gini index is 0.55, and in the US is 0.48. Are we doing okay here?
All good, all good, yeah.
All good, okay.
Thank you.
Thank you. The level of schooling in Puerto Rico, we can say that the literacy is above 92%, post-secondary education more than 48%, and high school diploma 27%. So you have an idea on the education. In 1994, well, the law was in before, right? In 1997, we initiated the Puerto Rico government health insurance. It was implemented by regions from 1994 to 2000 to the year 2000. Administrated public health care transferred from the government to private insurers. Expanded, was expected, the preventive medicine and screening, and the dental coverage was limited then, and 48% of the population who had the insurance utilized it or went to dentists. The law of June 1976 is actually the revision, which I'm going to talk now, the revision that which what we have right now, the Healthcare Plan 2020, 1.5 million persons are covered. The highest uninsured are the 25 to 34-year-old group. The less than 55, it's approximately 10% or insured. Dental coverage, 0.6 to 10%, was revised and expanded in that around 2020. So those are the situation in Puerto Rico and poverty levels and political situation with the United States that I wanted you to share. I wanted to share with you. So how globally the health inequality was approached. As you probably know, scientific committees present and discuss evidence of health inequality within and between countries. Social determinants was defined of health are conditions which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the condition of daily life. The report of the Commission on Social Determinants of Health was published in 2008, titled Closing the Gap in a Generation, Health Inequality Through Action on the Social Determinants of Health. The general recommendations improve living conditions from the Commission, fight against the unequal distribution of power, money, and resources, measure the magnitude of the problem, analyze and evaluate the effects of intervention. The Commission developed a conceptual framework. As you can see here, the aim of the framework is to highlight the difference between levels of causation, distinguishing between the mechanisms by which social hierarchies are created and the conditions of daily life which they result. Identify elements of policy directions for action, implied an analysis of policy approaches. I want to present now a paradigm shift in the health sciences, and this is what we're using here at the University of Puerto Rico. Health organizations, institutions, and education programs are encouraged to look beyond behavioral factors and address underlying factors related to social determinants of health. Clinical dental practice has been dominated by the biomedical and behavioral model. We're roughly describing here, not that it's one model to the other, but it's been enhanced, this model with the social determinants of health. So our discussion of health inequality at the School of Dental Medicine, we had the Academic Senate of the Medical Science Campus approved a proposal to strengthen the integration of social determinants of health in the Medical Sciences campus. Since 2012, the School of Dental Medicine had incorporated objectives and activities related to social determinants and interprofessional education into its strategic plan. The School of Medicine revised and incorporated in its curriculum the social determinants of health. Then the Office of the Assistant Dean of Research established a research and equity analysis unit. So those are our pathway towards addressing health disparities. So this is the curriculum aspect of it. So a little bit about the research and equity analysis unit. The purpose is to promote and conduct research aimed at reducing inequalities in oral and systemic health through collaborative interdisciplinary efforts and actions on the social determinants of health. Long-term objectives generate knowledge that involves dental and general education, health professional development, and ethical practice. Develop health policies, regulations, and interventions that seek outcomes that result in greater equity. The unit was started in 2014, and we're really working with the curriculum basically, and assisting other researchers. Our director, Professor Nazario, who has a doctorate in public health in social determinants of health, has been contributing in our grants this aspect of so much importance. This is another initiative of the University of Puerto Rico to address oral health disparity that it was established in 2015. But I want to highlight the major limitation that we have that actually limits us to address properly and efficiently the inequalities as the limited and non-existent epidemiological information. Puerto Rico doesn't have continuous epidemiological survey, although the US has the NHANES, we are not included. And I think how are we going to address disparities if we don't have that epidemiological data? That's our main concern here and the Caribbean. Other areas of importance are the limited staff in most of the islands. We're also having limited staff as well now after the pandemic, developing and reduce health disparities, interventions to reduce and prioritize oral health, and limited access, which is public policy. We have done some public policy with the results of some of our projects. So we also were lucky to obtain three major grants from NIH, National Institute of Dental and Craniofacial Research, and National Institute of Health and Health Disparities. The first one was a collaboration with New York University Oral Cancer Research in Adolescent and Adults Health Promotion. The PI was Dr. Katz, he's no longer with us, and I was the project director and local PI. So it was a U54 on oral cancer. They identified disparity, or the most important disparity identified was a deficit in biopsying potentially malignant oral lesions in Puerto Rico. So how did we address this situation, this disparity? We prepared some focus groups with UPR School of Dental Medicine alumni and coalition with the Puerto Rico Dental Society. And we found very interesting things. Basically that they didn't feel comfortable doing the exam, that they didn't had the skills for biopsies, that they had problems with the health reform, payment, etc. So how did we address this? We went to the curriculum and we included all these interventions and this education into our curriculum. We enforced the risk factors in one of the courses, and also community interventions. The community section here conducts several of them, and very effectively. They go to the elderly and with the students to do oral exams so that they feel more comfortable. And our group of the public policy, the committee, was able to establish a law, to recommend a law, and it was approved for Law 66 of 2006. There was a law already, but they expanded it to more public places, to all public places. And it's called Smoke-Free Puerto Rico. And the author of that was Dr. Diaz and the group of public health here. So this is the study that was conducted with the deficit in biopsy potential premalignant oral lesions in Puerto Rico. This was in 2007. The frequency of oral cancer and pharyngeal cases in Puerto Rico was disproportionately high, especially on men, relative to the frequency of persons with histopathologic diagnosis that would have appeared clinically suspicious for oral lesions. So it's a delayed detection. The percent of persons diagnosed with oral cancer were statistically different from Puerto Rico and Bellevue and NYU clinics. Puerto Rico, however, in more recent data, the oral and pharyngeal cancer has decreased an average of 0.7% per year on average, and however, 1.3% in year women has been an increase. So we used the research that we had to establish public policy, and we have seen that it's improving, and there's a lot of there's less smoking on the island, and definitely more exams conducted. Our second important disparity grant was Research Infrastructure Pathway Center in Oral Health Disparities. This was very interesting because during that, we identified dental caries, gingivitis, sealants, nutrition. It was a U24. We identified the disparity between public and private schools. And in addition, this grant had some funding for capacity building, where 5 faculty members were developed. All 4 of them obtained grants like K23, the S21, which is the endowment. And an excerpt of excellence was also by one of the 5 identified researchers paired with NYU researchers. This is our organizational chart. This is what we are right now. We have an Office of Assistant Dean of Research, and we have centers, cores, and units. There's a Center for Clinical and Research and Clinical CRCHP, Clinical Center for Research and Health Promotion. And then we have Dr. Dental and Craniofacial Research Core with Dr. Buxo. And then we have the Oral Biology and Cancer and Caries Control with an Oral Microbiology Lab, and so on. We have a pipeline, and then we have some support. I want to close my presentation with a quote from Dr. Watt. Any action on reducing social inequalities in health require active social participation and community empowerment. Once again, oral health professionals need the skills, experience, and insight to enable them to work effectively with community as local oral health champions and advocates for change. Thank you very much.
Thank you, Dr. Elias, for your excellent presentation. And now we'll continue with our second presenter, Dr. Sona Rivas Tumanyan. She's an associate professor of epidemiology and biostatistics at the Office of the Assistant Dean for Research and the Department of Surgical Sciences at the School of Dental Medicine, University of Puerto Rico. Dr. Sona Rivas Tumanyan has a master's degree in public health, specialty in epidemiology and biostatistics from Boston University, and her doctorate degree in public health with specialty in epidemiology from Harvard University. So I leave you now with Dr. Rivas Tumanyan.
Hello, everyone. Today I will be talking about results of some of our research conducted here at the University of Puerto Rico School of Dental Medicine, with a special focus on the health of 12-year-old school children and health disparities by socioeconomic status. So there were 2 cross-sectional studies conducted with similar methods in 1997 and in 2011 with the purpose of evaluating the status of oral health among 12-year-old Puerto Rican school children. They both used probabilistic sample of schools. So there were clusters of schools spread out throughout 11 health reform regions. And they were using for oral health evaluations, they were using an IDCR 1991 evaluation criteria. So the schools were stratified by the status of public school versus private school. And within the public school system, we also separated them by the area of residence, urban versus rural. We aim to have about 50-50 distribution of boys and girls in our sample. You can see the numbers here. The sample size for the analysis was more or less equal, about 1,400 in 1997 and about 1,500 in 2011. Here in this slide, you can see the distribution of the sampled schools in 2 studies. The triangles indicate the 1997 selection, and the green circles show 2011, separated by the regions, health regions. So mainly, most of the data was collected in both studies, but with some differences. So oral health was evaluated among 12-year-olds in terms of caries distribution, pit and fissures, sealants, gingivitis, and calculus. In 2011, we also had anthropometric measurements, the height and weight measured directly. In a subsample in 2011, we also had a 24-hour recall diet questionnaire which allowed us to evaluate for the diet and nutrition. And also in most of the school children, we evaluated other risk factors and oral health knowledge and behaviors, some of them in a subsample as well. Since we used a probability sample, we later weighted our data using inverse probability weights, which were later normalized to avoid inflation of the study sample and power. We accounted for clustering of observations by school, and we used regression models, which allowed us to account for clustering and weighted the sample for some regression models and logistic regression models, depending on the outcome. So today I will be focusing on the type of school as a proxy for socioeconomic status, and it will be for most of the presentation, it will be separated in three groups: private, public urban, and public rural. However, we did also look into comparisons by biological sex and health region, and you can research that later using the references at the end of the presentation. So when we looked at the caries prevalence, we could see that in 1997, the prevalence was quite high. In private schools was 75, in public schools was about 80s, in the 80s, and the differences between the private and public schools were statistically significant for public-urban comparison. So the p-values here up on the columns represent the comparisons with the private school attendees. In 2011, which are the orange columns, you can see a drop in caries prevalence. However, the differences between public and private schools were still there, and this time also statistically significant. Similar picture was when we looked at DMFT as the measure of caries extent, and overall we could see a drop in DMFT between 1997 and 2011 data, but again, the differences between public and private schools were still there. Similar picture in DMFS, we could see a big change, big drop in DMFS in all schools. However, still significant differences. The p-values were highly less than 0.001 for comparisons versus of public schools versus private schools. We also looked into components of DMFS, and we could see changes in DMFS component distribution. So in 97, which is the inner circle, we had 42% of the surfaces decayed and about 50% of them filled, with 8% being missing surfaces. However, in 2011, we could see a larger proportion of DMFS being attributed to filled surfaces, with a drop in missing as well. We looked at the sealants as well, and as you can see, the sealant prevalence, which was defined as having at least one sealant on one permanent first molar, was very low in 1997, about 11% in the private schools and much less in public schools. And you could see, based on the odds ratio, the odds of having a sealant among public school attendees were 5 times lower. And in 2011, the gap was less. However, still statistically significant differences between school children enrolled in private schools and public schools, with the odds ratios in 0.6 and 0.57, which was similar. Gingivitis was also measured in 2011. We had different definitions of, we used different definitions of gingivitis based on bleeding on probing. And overall gingivitis prevalence was more or less similar. Same could be said about extensive gingivitis in 2011 between 3 groups of school children. However, when we looked at the continuous measure of percent of sites with bleeding on probing, the average was higher. Average number percent of sites with bleeding on probing was higher for public urban school children compared to private school attendees. Calculus distribution was similar in 3 groups. You can see the numbers here. We measured both supragingival and subgingival calculus prevalence, and the p-values are presented as well. We also looked at the general health of these school children with a focus on nutrition and relative weight. And we had we looked at overweight and obesity. And in our research, we discovered that in 2011, the prevalence of overweight and obesity was high in Puerto Rican school children. There was no statistically significant difference between children attending public versus private schools. However, again, prevalence was quite high, which calls for possibly development of prevention programs and intervention programs. The diet based on 24-hour diet recall data was evaluated using a Health Eating Index 2005 index. This index has components attributed to different types of foods consumed by survey participants. So what we discovered is that overall, 2005 index was similar in two groups by school type, and two groups because here in this analysis, we looked at private versus public. However, when we looked at different components of the index, children attending public schools had higher scores for total fruit, whole fruits, vegetables, dark green and orange vegetables and legumes, and total grains, whereas children attending private schools had better scores for whole grains, milk, and sodium. So we also looked at the micronutrient data coming from the 24-hour recall, and in this research we discovered that the micronutrient intake was below the recommended levels, and this can be mitigated by supplement use, multivitamin and multimineral supplement use. And we looked at the self-reported supplement used by school children, and we discovered a significant difference. We can see that in public schools, nearly 7% reported use of multivitamin and multimineral supplement versus about 18% of private school attendees. And these differences were statistically significant. So in conclusions, as a result of our research in two different time points in 97 and 2011, we saw that dental caries prevalence and extent among Puerto Rican school children has improved. However, disparities by socioeconomic status, as using our proxy of type of school, still persist. And same thing can be said about the prevalence of sealants. It remains low, and disparities still are there between school children by socioeconomic status group. Gingivitis prevalence was high, and even though the prevalence was not different between the different school type attendees, percent of sites with bleeding or probing was higher in public school attendees compared to private school children. We did discover a high prevalence of obesity and overweight in our population, and some components of diet were associated with socioeconomic status. And of course, micronutrient intake that can mitigate deficiencies from the diet intake are below, and the supplement intake that can mitigate was lower in public school attendees compared to private schools. And I would like to thank the study team in both studies, and these are our funding resources. And the references are at the end of the presentation. We can provide them so you can look into more detail of our results from two cross-sectional studies. And the next speaker, I would like to introduce Dr. Carmen Buxo. She's a professor and director of Dental and Craniofacial Genomics Core and the Caribbean Dental Biorepository here at UPR School of Dental Medicine. She is also mentoring coordinator at the postdoctoral Masters of Science of Clinical and Translational Research at the Schools of Health Professionals and Medicine. She has a doctoral degree in public health, a specialty in environmental health, and a master's degree in public health with specialty in epidemiology, in genetic epidemiology at the University of Puerto Rico. And I would like to welcome her here to continue this presentation.
Thank you, Dr. Rivas Tumayan, for your presentation. Let's continue with mine. I will be speaking about a study of genetic and environmental risk for oral clefts in Puerto Rican Hispanics. This study is a collaborative effort between the University of Puerto Rico, the University of Iowa, and the University of Pittsburgh, and it's sponsored by the National Institute of Dental and Craniofacial Research. Orofacial clefts are one of the most common birth defects worldwide, and they are also a global oral health inequality due to differences in access to care, poverty, education, ethnicity, or being in a marginalized group or minority group. They have comorbidities that include shorter lifespans, psychiatric disorders, and cancer, among others. These patients require several surgical, dental, nutritional, speech, and behavioral interventions. And the patients and their families receive substantial economic and societal burden. Many of them, especially during childhood, many of them face social discrimination or bullying. Orofacial clefts are multifactorial and polygenic birth defects involving detoxification and development and metabolic genes that have been associated previously in the literature. Also, there's a maternal exposure component associated with the increased risk of orofacial clefts that include, folic acid, vitamin deficiencies, smoking and alcohol consumption, occupational hazards, medications, infections, and other comorbidities or health conditions such as diabetes and metabolic syndrome. Puerto Rico has a birth prevalence of oral clefts of 17 per 10,000 live births as for 2017. This prevalence has increased in the last decades. It's higher than other territories and states in the United States, and it's the highest in the Caribbean, and comparing also with other Latin American countries. This is the geographic distribution of the birth prevalence of orofacial clefts in Puerto Rico, observed in this map with different shades of blue, or the highest rates with the darker blue or purple color. The Puerto Rico rate is, can you see the, oh, sorry. Can you see the cursor? Yeah. So yes. There's a cluster of cases in the northwestern region of Puerto Rico that you can see in the circle. And it has a higher prevalence rate than the Puerto Rico rate, which for this period was 15.89. So you can see that this area has between 22.7 and 45.60 prevalence rates. And this comparison was statistically significant. So there's a lack of studies that evaluate the etiology of orofacial clefts in Puerto Rican population. So we aimed to determine the different genetic factors and maternal exposures associated with non-syndromic orofacial cleft risk in Puerto Rican children by identifying candidate genes from previous recent genome-wide association studies, sequencing to identify several variants that are unique to our mixed population, study gene-environment interactions, and ancestry analysis. Here are some of our preliminary findings about the selected or distribution of selected characteristics. This is a case control study. Here we have around 309 participants. So overall, there were no statistical differences between cases and control for sociodemographic variables, including income, paternal education and maternal education. This table represents the selected maternal exposure covariates that we analyze between cases and controls. I want to highlight that there were no statistical significant associations between maternal smoking before and during pregnancy, alcohol consumption before and during pregnancy. However, alcohol consumption during pregnancy had a 2.6 odds ratio, even though it was not statistically significant, which is important to highlight. The next table represents the odds ratios for maternal exposure covariates, including multivitamin use and folic acid use 6 months before pregnancy. So there was a protective association found for multivitamin use before pregnancy with a odds ratio of 0.56. But however, we did not find a statistical association for multivitamin use during pregnancy. For maternal folic acid use 6 months before pregnancy, we also saw a protective association of 0.36, but the same pattern for folic acid use during pregnancy. It was also protective, but not statistically significant in this sample. So the findings for this part of the study has been that we have found a higher risk for mothers that did not use folic acid before pregnancy. We saw an evidence of gene-environment interaction for a genetic variant, MTHFR, which is a gene related to the absorption of folic acid use and the intake of folic acid before pregnancy in our sample. We have been able to identify around 22 novel and rare genetic variants that have not been studied or reported either in Puerto Ricans or Hispanics. And this contributes to the list of mutations and variants found in the etiology or of orofacial clefts worldwide. We have been also been studying metabolic syndrome and its association with orofacial clefts. Why is it important? Because metabolic syndrome prevalence was 25% between 1999 to 2006 versus 34% between 2007 and 2012 among adults of 18 years old in the United States. Metabolic syndrome and orofacial cleft prevalence has increased in the last decade in Puerto Rico and in Hispanic populations. And previous studies have implicated maternal type 2 diabetes and gestational diabetes, obesity, and hypertension with an increased risk of orofacial clefts in the offspring. So we selected a diabetes panel for SNPs of 24 SNPs and obesity panel for mainly associated with BMI. And we study its association with cleft risk. We have identified, as you can see in this scatter plot for the diabetes SNPs or panel, that the transmission disequilibrium test for, we had trios, around 300 trio analysis. We were able to identify these 4 genes related by any type or cleft lip with or without cleft palate, cleft lip, and cleft lip and palate. However, the only one that meant Bonferroni correction was IGF BP2 with a p-value of 0.002. Here are the forest plots of the significant SNPs in the diabetes panel and its odds ratio for the different types of clefts, combining all the analysis by case control, the trio or transmission disequilibrium test, and the meta-analysis, which combines both of them. We were able to identify these 3 genes and by different types of clefts. In conclusion, no significant differences were observed between analyses for any of the BMI SNPs and the diabetes SNPs by cleft palate only. One of the SNPs, only one of the SNPs in the diabetes panel, IGF-2BP2, was significantly associated with a reduced risk in cleft lip in Puerto Rican Hispanics after the bone-for-only correction. And we are performing an ongoing analysis to adjust for covariates, maternal covariates, with the phenotype information such as BMI, gestational diabetes, and type 2 diabetes. Future analysis should be done in other populations, especially at mixed populations, are needed to confirm the genetic relationship between metabolic syndrome and orofacial clefts. We foster community involvement also in our studies to reduce social inequalities in maternal infant health, including health education, informing the community, supporting other maternal infant health research, and increasing awareness in these populations. We also foster and engage in mentoring with our college students, our dental students, medical students, public health students, and postdoctoral students. And they present nationally and internationally. I want to acknowledge for this study the participating families, our collaborators at the University of Pittsburgh, especially the University of Iowa, Dr. Butali Lab, their staff and students, our staff at the University of Puerto Rico and students. And this study has been supported by several these grants from NIH and UPR institutional funds. Our other project is the Caribbean Dental Biorepository, or CARIDEN, which is the first saliva and dental repository in the Caribbean and at the UPR School of Dental Medicine to store salivary DNA for precision medicine initiative, such as the All of Us from the National Institutes of Health. Here is our contact information. And now we continue with our next presenter, Dr. Evangelia Moro Bermudez, which is a professor in oral biology at a School of Dental Medicine, University of Puerto Rico Medical Sciences Campus. She studied dentistry at the University of Athens, Greece, and then completed a pediatric dentistry and advanced education general dentist program at the Eastman Dental Center at the University of Rochester, New York. She also completed a PhD in microbiology and immunology at the University of Rochester. So now I leave you with Dr. Evangelia Moro.
Thank you, Carmen, and thank you all for watching. So I'm going to be talking to you today about one of our more recent projects at the University of Puerto Rico. This is Project Helios. And the Helios is an acronym for Hurricane Exposures and Long-Term Infant Outcome Study. So Helios is a project about mothers that were pregnant during Hurricane Maria in Puerto Rico and their babies. But it is a lot more than that, as you're going to see, because we're collecting so much information here that is going to help us understand better the biological mechanisms by which our early life experiences can affect our future, the future development and health of babies. So the project is funded by a grant from the National Institutes of Minority Health and Health Disparities with an additional supplement for NIDCR. The principal investigators of this grant is myself and Carmen Buxo, that you know. We also have the third PI, who's a psychiatrist, Dr. Karen Martinez. She's actually a specialist in the management of fear and anxiety. And as you're going to see, mental health is one of the central themes in Project Helios. So as you may have heard, Hurricane Maria was a Category 4 storm that struck Puerto Rico on September 20th of 2017. It was a very traumatic experience for all of us who lived through this. And what happened afterwards was even worse. So the hurricane completely destroyed the island's electric systems, water supplies, communication systems, health systems. Everything was affected for several weeks, and actually most people did not have electricity for months. So all these exposures were found seem to have led to more than 4,000 excess all-cause deaths on the island. So Helios is based on the developmental origins of health and disease theory, which basically says that early life exposures to different stressors, including environmental stressors, prenatal maternal stress, and diet, can cause adaptive phenotypic change responses, which may increase the risk for different diseases later on in life, including cardiometabolic and psychiatric diseases. And of course, the exact mechanisms through which this happens are not completely understood, but it is believed that epigenetic mechanisms are the interface through which the body interprets a response to these stressful experiences in early prenatal and perinatal life. In Helios, we also hypothesized that the different hurricane related exposures could also have affected the early microbiome of the affected infants, and that also could have and we want to see what would be the long-term impact of that as well. So what is happening in Helios is this. We're measuring different stressors prenatal stressors related to Hurricane Maria in the mothers. So we're recruiting mothers who were pregnant during the hurricane and their babies. So we're looking for we're measuring two types of stressors. One is objective stressors related directly to the hurricane, such as property loss or damage, and how long you were without electricity, nutritional diet, and all those things. And we have validated questionnaires that we use for that. And we also measure maternal mental health, symptoms of anxiety, depression, PTSD in the moms, which is a more subjective measure, like shows how the mothers interpreted what happened to them during the hurricane. So we're collecting blood samples from the babies for epigenetic analysis, and also stool samples and saliva samples to study the gut and oral microbiome. And we're collecting a lot of information about pregnancy history and pregnancy outcomes. And we're also performing clinical assessments where we're measuring growth, developmental milestones, temperament, as well as oral health in the mothers and the babies. And of course, our goal is to create all this, to obtain all this baseline information and develop this cohort with the goal of following up those babies in the future to evaluate the possible long-term effects. So here's where we are right now. We have recruited 187 mother-child diets. We were hoping for 200, but as you can imagine, the recent pandemic had made it very difficult for us. So we are very happy with the number we have. Here you can see some of the main demographic characteristics of our study group. The children were on average 24 months at the time of the evaluations. We don't see any major differences in pregnancy outcomes compared to the Puerto Rican, the standards for Puerto Rico, including preterm deliveries and mode of deliveries. But we do see an increased prevalence of maternal mental health symptoms, such as symptoms of depression, stress, and PTSD in the mothers. So we're just beginning our analysis, our statistical analysis of all this data, and Sona, that you met before, is in charge of that. I'm just going to briefly mention some of the most important findings that we have so far. First of all, we have just completed a pilot epigenetic analysis on a subgroup of children from mothers with high levels of maternal stress versus low maternal stress. And this was done by Dr. Alex Vieira and Erin Kello at the University of Pittsburgh. The manuscript is under review right now. We did see that significant difference in DNA methylation associated with maternal depression, PTSD, and also with some objective exposures such as property damage. However, the most important factor that seemed to have impacted the epigenetic profiles on these children is the timing of the hurricane in relation to the pregnancy. So we have identified about 30 CPG single probes associated with the timing of the hurricane most of them hypermethylated, and including one true differentially methylated region, or DMR. This DMR is associated with a gene that appears to be involved in cardiac function and cardiomyopathy. And most importantly, most of the differences in methylation have occurred in children that were at 20 to 25 weeks of gestation when the hurricane struck, which is a very important information that can help us target our attention to this specific group. We are already seeing some significant associations between prenatal maternal stress and child outcomes, specifically with child development and temperament. So mothers of children with high PNMS have children, their children have a significantly lower probability of meeting developmental stones for their age. And temperament, we're seeing a positive as an association between PNMS and reduced effortful control and surgency scores. These are aspects of the child's personality which are related with how the child controls their emotion and their good nature. And they have been associated with possibly increased risk for future mental health problems. As I told you, we're also including oral health examinations, and we do see a 26% prevalence of ECC in the children. And interestingly, we're already observing a positive association between maternal depression and stress symptoms with a number of decade achieved. So where we're going with Helios is, of course, our goal is to identify symptoms of potential problems in the mother and the children that might require close monitoring in the future. We hope that it will help us to develop guidelines for special needs of pregnant women and babies during disasters. We are creating this cohort, this birth cohort of Hurricane Maria babies, so we can study the long-term impact. And most importantly, as I mentioned before, we are hoping to use this information to understand better the biological mechanisms through which early life experiences may impact a child's health in the future. As you can imagine, this is a huge project, interdisciplinary project, and we have been very lucky to have some wonderful collaborators in epigenetics, biostatistics, pediatricians, neonatologists, dentists. We have a huge research staff that helps us, that includes nurses, phlebotomists, lab technicians, coordinators, and of course, a large number of students that are helping us, which we're very thankful for. And of course, we have support by NIH for all that. As Carmen mentioned before, we're trying to be very active in the community that not only help us to find these moms, but also to raise awareness about the importance of maternal mental health, especially during the perinatal period based on our findings. And of course, we're very thankful to the mothers who participate and all our students. And I'm gonna leave you here.
Thank you, Dr. Evan Moreau Bermudez. So now we're just starting the discussion session. Any questions? Any questions in the chat?
Carmen,
So,
I think, can you see the chat now?
Yes. Yes.
Okay, great.
So Dr. Mosi says, thanks to everyone, excellent presentation, really important work in this health inequality space. A couple of minor points in terms of methods for Professor Sona. Do you feel that bleeding on probing is the best measure for gingivitis? And for Carmen, for me, for those setting up biorepositories to investigate cleft lip and palate etiology, would you recommend blood or saliva? I'm gonna address my question first. For the orofacial cleft biorepository, so for studying genetics and other omics, it would be better collecting blood. But if it's not possible because of a higher yield for DNA, but if not possible, we collect, in our case, saliva for those babies or children that are not able to donate their blood. So I leave you now with Dr. Sona so she can answer Dr. Mosey's question.
Thank you for the question. So in terms of gingivitis measurements, since we were looking in a population-based setting, the exams were done in the schools, we felt that bleeding on probing was the best way, the possible way logistically to evaluate gingivitis, to identify any health disparities and the need for prophylaxis. And to be honest, yes, we did look at it at different definitions of gingivitis based on the measurements that we collected. I showed you the overall prevalence and the limited gingivitis and extensive gingivitis. And only the continuous measure of percent of bleeding on probing, percent sites with bleeding on probing came out statistically significant. However, that allowed us to identify a group of school children that could possibly benefit from a school program to initiate toothbrushing. And so this program is in process. It's being developed and soon to be started in certain schools in Puerto Rico to target more frequent and more efficient toothbrushing among school children. Yeah. Any other questions?
Thank you, Sona, for your answer. There's also a comment for congratulations, excellent presentations. Thank you everyone for these presentations, great work. University of Puerto Rico, thanks for sharing with us. So it's almost time, well, we're past time. If there aren't any other questions, we want to thank you for your attention and your attendance, everyone. And if you have any questions, you can also email us. We hope to see you in our next GOHIRP webinar. And thank you for being with us today. Have a great day.
Thank you, Carmen.
Thank you, Carol.